Hello, my name is Ruben Mesa, and I'm the Executive Director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. And delighted to be joined by this wonderful panel of experts in myeloproliferative neoplasms for us to take a deep dive in myelofibrosis. We're grateful to Blood Cancer Today for us to be able to share with you some of the exciting updates on the diagnosis and therapy of patients with myelofibrosis. But let me go around and have my wonderful colleagues introduce themselves to share a little bit about their practice and experience with the MPNs. Naveen, why don't we start with yourself?
Well, thank you, Ruben, for having me here. Naveen Pemmaraju, Professor of Leukemia at MD Anderson Cancer Center.
Wonderful.
Thank you, Ruben. Sanam Loghavi, I'm a hematopathologist and a molecular pathologist at MD Anderson, and I focus on myeloid malignancies.
Hi, I'm Olatoyosi Odenike from the University of Chicago. I'm a professor of medicine and director of the leukemia program there, and see a wide array of myeloid malignancies, including myeloproliferative neoplasms.
So why don't we start at the beginning? As it relates to patients with myelofibrosis, what does the modern workup look like? What is that kind of key diagnostic standard in terms of the tests that are done? So Sam, why don't you start us off? Again, as a hematopathologist, what are some of the key things you think are necessary as we both diagnose and risk stratify our MF patients?
Sure. So, again, being a traditional morphologist at heart, I think really still morphologic evaluation of the bone marrow is critical. So I would say, having a bone marrow aspiration and a biopsy. And with that comes traditional, conventional karyotyping. We need to risk stratify the patients molecularly at baseline, so having at least a basic myeloid NGS panel is necessary. And then now with some of the newer techniques, we've started doing optical genome mapping on some of the myelofibrosis patients. Again, this is to detect some of the some of the cryptic abnormalities that we may not detect on traditional conventional karyotyping. But at the minimum, we need morphologic evaluation, molecular, to look for mutations, so next generation sequencing, as well as conventional karyotyping.
Olatoyosi, the U of C kind of clinical workup piece, we've heard a bit about the hematopathology piece. One comment, did you guys have an NGS panel on all patients with MF upfront? Two, anything else that is distinct? Do you feel the need to do any imaging to objectify kind of the size of the spleen?
No, we do not do any imaging to objectify the size of the spleen. We do that at the bedside. We only do imaging of the spleen if the patient has symptoms, they're complaining of pain or something unusual where we want to take a deeper look, or if we are screening the patient for a clinical trial. Usually, splenomegaly in myelofibrosis is not a subtle finding. A good clinician can figure that out at the bedside. In addition to all the tests that Sanam mentioned, we also often will HLA type the patient at the time of presentation, knowing that allogeneic stem cell transplant is the only path to a cure, and that until proven otherwise, a diagnosis of myelofibrosis may render a patient potentially eligible for an allogeneic stem cell transplant.